Hello, I'm Dr. Paul Cremer. I'm a cardiologist and a cardiovascular imager at Northwestern University, where I am an associate professor of medicine and radiology. I'm the director of multimodality cardiac imaging, and it's my pleasure today to be facilitating a discussion about sarcoidosis. What are the best practices as it relates to patient preparation, processing, and interpreting the studies? I'm joined today with Dr. Hutt. Dr. Hutt, it's good to see you.
Hi. Hi, everyone. My name is Erika Hutt, and I'm a cardiac imaging fellow at Cleveland Clinic. I'm also a member of the ASNC Leadership Development Program, and I also have a master's in clinical research from Case Western Reserve.
Excellent, thank you. And we're fortunate today to be joined by with Dr. Ed Miller, who many of you know. He's an associate professor of medicine and radiology in the section of cardiovascular medicine at Yale. He directs the clinical nuclear cardiology laboratory at Yale New Haven Hospital, as well as the cardiology fellowship program for the Yale School of Medicine. Dr. Miller, it's great to have you with us.
Nice to see you both.
So, I think we all appreciate how challenging the care of these patients can be, how challenging the interpretation of these studies can be. So I think it's great to have some time to get into some of the specific things that I think come up in our daily clinical practices for those of us involved in these multidisciplinary cardiac sarcoidosis teams. So I'll start with the first question, Dr. Miller. I think first off, when should we think about obtaining a cardiac PET to evaluate for sarcoidosis? And I think that's sort of in two broad buckets. The patient with known extracardiac sarcoid, which of those patients should we think about obtaining a cardiac PET? And then the second group is what about the patient with suspected isolated cardiac sarcoid? So how do you approach that in your clinical practice?
Sure. Yeah, thanks. That's a great question. And how I like to approach that question is to think about patients with cardiac sarcoidosis is to add the descriptor of whether it's acute or chronic cardiac sarcoidosis. Mm-hmm. Right? We should be thinking about FDG PET imaging in terms of diagnosis and therapeutic changes in defining patients who have active inflammation that we want to act upon. If we think about people who have acute cardiac sarcoidosis, those are generally people who are presenting with a presentation of acute complete heart block or much less commonly malignant ventricular arrhythmias, where you want to make a diagnosis of active cardiac inflammation. So those acute complete heart block patients are really important ones who may or may not have known extracardiac sarcoidosis. The other patient population, obviously, are patients who have a presentation that has acute symptoms, who may have been screened initially with a cardiac MRI that's abnormal. I tell all my patients that those cardiac MRIs are, in general, very effective for looking at myocardial scarring, to some degree inflammation, but we really want to use FDG PET as the gatekeeper to establish inflammation, to establish the need for immunosuppressive therapy. So those two patient populations, whether they have known extracardiac sarcoidosis or even those who don't have known extracardiac sarcoidosis, acute complete heart block, or prior abnormal cardiac MRIs. In particular, the suspected isolated cardiac sarcoidosis patient presents another opportunity in those patients that you want to look for sources for potential extracardiac disease that may be active. So mediastinal lymph nodes or pulmonary parenchymal or abdominal findings that are consistent with active cardiac sarcoidosis. So I think those patient populations, focusing on those with acute presentations, are the ones that in general I go to as the ones that deserve an FDG PET.
Okay, now I'll ask you a little bit about patient preparation, because I think this is where most of the challenge lies with cardiac imaging cardiac inflammation using F18 FDG PET. What are, in your opinion, the best methods for patient preparation for these studies, and do you check serum ketones prior to tests?
Yeah, very great. Thanks, Dr. Hutt. Great question, and one that has a lot of been a source of a lot of discussion, and we should obviously realize that we don't have the evidence-based answer to this question. But in general, we want to utilize patient preparations that shift the myocardial metabolism from glucose to free fatty acids in order to null the myocardium and image inflammation with 18-FDG. The strategies that have been utilized to do that more effectively have used combinations of high-fat, low-carbohydrate ketogenic diets, along with prolonged fasting. We should realize that short-term fasting is used for oncology pets, for example, is not sufficient to null the myocardium. The protocol that we use at my institution, which I think is fairly commonly employed, though not universally, is a 1 day long prescribed high-fat, low-carbohydrate diet, finishing at dinner time around 6 p.m., and then absolutely nothing but clear water from 6 p.m. until the study's performed, which in our institution is generally mid-morning, 9 to 10 a.m. So it leads to about a 15-hour fast. The duration of the fast, I think, is more important than the strict dietary preparation, although in some patients, those who have non-specific uptake after this preparation, a prolonged diet has anecdotally been shown to be more effective. We don't regularly check ketones prior to our studies. I think that area, to check circulating markers of metabolism and the effectiveness of the diet is an area that we should all be looking for further investigations in the coming years.
Thank you.
That's great. Thank you, Dr. Miller. And to get into some more specifics of how to perform the test, what do you see as the role of myocardial perfusion as part of the FDG study? Should it be routinely performed, and how do you use that in your lab in terms of interpreting the study?
Sure. So the utility of, so historically, myocardial perfusion imaging has been performed in combination with FDG imaging for cardiac sarcoidosis for two reasons. The first is to define whether there are areas of abnormal myocardial blood flow consistent with myocardial scar formation. This can be a potent risk marker for prognostication. So patients who have an area of scar large enough to be seen by perfusion imaging generally would have a worse prognosis. In addition, patients who undergo this imaging, the rubidium image can be useful for co-registration in determining myocardial contours of the FDG imaging to align those for more accurate interpretation. I think that in my opinion, is less useful because of imaging strategies for interpretation that I think we'll talk about later, but they can be utilized and is utilized by some of the commercially available programs. In addition, I think it's important to point out that some of the randomized clinical trials that are ongoing currently, enrolling for the determination of effective strategies for treatment of acute cardiac sarcoidosis, use the defect size on myocardial perfusion imaging as a primary endpoint for their clinical trial. So we think it's effective as a risk assessor. It can be useful for helping with our image interpretation and for understanding the total disease burden, particularly in those patients who may not have had a cardiac MRI to determine scar prior to their FDG imaging.
Those are great points. And along the same lines, what are your thoughts on, does every patient need a whole body PET as part of the exam?
Sure. So whole body PET imaging for FDG, as you know, uses a different CPT code than does myocardial metabolic imaging. And depending on your institution, particularly those with Medicare in local Medicare treatment and reimbursement decisions, your institution may or may not have the capability of performing a larger field of view CPT code whole body FDG imaging. I know there's differences between my institution and other institutions in the East Coast in terms of how our Medicare agencies view those types of imaging approaches. In our laboratory, we routinely do single bed position cardiac focused imaging. We would love to be able to do more extended field of view imaging from for example, skull base to mid thigh. particularly in those patients who have who were looking for extra cardiac disease and want to find the presence of sarcoidosis if they have a presentation that's consistent with isolated cardiac sarcoidosis. Those patients should really be pushed or we should try to advocate for whole body imaging. Whole body imaging does open up some complexities to it, and not only from the billing perspective, but from the interpretation perspective. Those will require the collaboration with nuclear medicine physicians and or radiologists for review of the FDG findings in multiple non-cardiac territories. For repeat imaging, for patients who undergo sequential imaging for determination of therapeutic efficacy and titration of immunosuppression, my personal opinion is, in general, decisions should be made on the inflammatory burden in the heart on PET imaging. And in those cases, cardiac-focused imaging appears to be all that's needed for follow-up exams.
Excellent. Thank you, Dr. Miller. And I think that aligns with our practice as well in terms of the approach to serial imaging in particular. Now to get into some of the specific patterns that we can see, I think one pattern that often leads to a lot of consternation in the interpretation is when you have normal perfusion. So say you have normal rubidium perfusion and you have isolated lateral wall FDG uptake. Mm-hmm. How are you handling that scenario in your lab?
Yeah, thanks, Dr. Cremer. That's a very confusing and controversial to some degree imaging pattern. I think it deserves, this is where we should be providing a comprehensive review of the patient's entire case as we interpret the scans, because we need to know some specific factors as we determine the post-test probability that the abnormality represents active cardiac inflammation. So the clinical presentation is really important. If they're presenting with acute complete heart block and the only FDG abnormalities in the lateral wall, then it's most likely not the source of their acute presentation, where their FDG abnormality should be in the area of the AV node. In addition, in patients who have a less specific presentation, for example, those patients who may be on the older side and or being assessed for things like PVC burden and maybe some abnormal lymph nodes or nodules on CT imaging, but don't have defined extracardiac sarcoidosis. I don't personally believe that lateral wall only uptake should be the sole arbiter of the initiation of immunosuppression. Right, those patients' lateral wall uptake is not normal. We shouldn't call it normal, but we should have a very generous caveat in our reports saying that it's something to the effect of there's lateral wall only uptake without any extra cardiac uptake or other features suggestive of cardiac sarcoidosis. This is abnormal and nonspecific, and caution should be used in interpreting this as consistent with active cardiac inflammation. That's how we approach it at our institution.
Thank you. And regarding quantification of FDG uptake, do you quantify the uptake, and what are the best approaches to do so?
Yes. So we've come a long way on this. I'll take a little bit of credit for this. Two papers over a decade ago where we developed that methodology of cardiac metabolic activity and cardiac metabolic volume based on using thresholds of the left ventricular blood pool or other background FDG values to determine the abnormal FDG set point for determining abnormal cardiac metabolic thresholds. Now, realizing that those thresholds and those values of 1.5 times LV blood pool were determined, over 10 years ago on older 2D systems in patient populations that I think that we're still learning a lot about. So what we found over time is that the volumetric measures that incorporate volume of abnormal FDG pixels and then the volume times the mean activity in those regions can add some degree of value, but they're not without their pitfalls. For example, simply because there's a small area of abnormal volume of low intensity. I think that should be interpreted with caution as being a true abnormal area of myocardial inflammation. I think what's more important, though, is to ensure that whatever imaging system you're using to interpret your imaging is displaying the images using an SUV-based scale. So remember, these are hot spot images. They're not cold spot images. So our software systems that we use for daily practice of interpreting our rubidium images or technetium labeled perfusion images are not designed in most cases to handle hot spots. They're designed to normalize all the image intensity to the hottest area of the image and make cold spots look colder. So those imaging systems, the commercially available myocardial perfusion imaging systems in general, don't allow us to know the peak activity or to set the image intensity to reflect that peak activity. So we recommend that the image interpretation of the perfusion starts on the commercially available perfusion systems, but then you switch to a hybrid imaging system, and there are multiple different options out there that most institutions will have. So you're able to review the fused FDG CT image using an SUV-based scale, usually 0 to 7 grams per ml, or sometimes 0 to 5 grams per ml, because those approaches allow for the image to be displayed in an intensity that's consistent with areas that are generally considered abnormal. If you don't do that, then if you use normalized image intensity, there's about a 10 to 15% likelihood that you're going to overcall areas of mild uptake, particularly, as Dr. Cremer was asking, in the lateral wall of the left ventricle.
Thank you, Dr. Miller. That was fantastic, I think, practical advice as related to the interpretation of the FDG images. You touched on this a little bit, but I wanted to go in a bit more depth, and that is, who do you perform serial testing in? What should be the frequency of the serial testing? And how do you sort of incorporate that into your clinical decision making?
Right. So serial testing is an important aspect of how we should use FDG PET imaging. And what I'm about to, this approach that I'm about to use as our institutional approach is similar to what's in the guidelines, but it's obviously not based on any evidence showing that it's superior to any other testing strategy. But I'll describe our approach. The first is the recommendation that anybody who you want to start an immunosuppression for cardiac sarcoidosis should have active inflammation that you can follow on FDG imaging. I think that's a generally accepted truism. So we'll start with that baseline FDG scan as the initiator of the trigger for the initiation of immunosuppression. Then our approach is to keep people on therapeutic immunosuppression for somewhere on the order of 3 to 4 months. Some institutions will go longer, 4 to 6 months. But we've in general found, I think that this is borne out by most of the data, that about 4 months of immunosuppression has been effective for most people in reducing cardiac inflammation. We'll repeat a second scan while on therapeutic immunosuppression to validate that at the end of that therapeutic course, immunosuppression has been effective at reducing the cardiac inflammation that was there present. At that point, my practice is to taper immunosuppression over several months down to a low maintenance level, somewhere on the order of 5 to 10 milligrams a day of prednisone. At that point, we will repeat a third set of imaging to ensure that we haven't had a rebound in the immunosuppression. I think that third scan is a little bit more controversial. That's certainly not something that I think is validated by guidelines, but something that we've found to be helpful in clinical practice. After that third scan, it becomes more of a clinical decision maker. Certainly, any acute change in LV function, acute changes in conduction, or in some cases, changes in ventricular arrhythmic burden, particularly polymorphic ventricular tachycardia, could be an indication for a fourth or follow-on scans. What I don't think are generally helpful are routine follow-up imaging in patients who are clinically stable and have no changes in conduction, arrhythmic burden, or LV function. In those patients, In most patients, I found after that third scan, we talk to folks about, we're going to monitor your device, and assuming most people at that point will have a device. We're going to monitor your QRS and your PR intervals. We're going to monitor your PVC burden and LV function by echo. But we won't routinely go back and say every year we're going to do a follow-on scan to look for cardiac inflammation in the absence of other clinical changes.
Thank you so much. I'm just going to add one more question there. What about in patients that have persistent FDG uptake with little?
Oh yeah, nobody does after steroids. No, that's a great question. So the scenario would be, I think, a rebound scenario on that third scan, for example, in somebody who had complicated cardiac sarcoidosis, and I can think of patients who've had, mildly to moderately decreased LV function, scar burdens, and multifocal FDG on their initial 2 sets of imaging, for example. I think though, if you saw that on a second or third scan, you would want to consider switching immunosuppression, and then I think starting the process again to follow on for the effectiveness of whether it's a different immunomodulator, biologic agent, etc.
Thank you so much. Well, this was an amazing discussion. I think I learned a lot, and I'm sure that the viewers are going to be also very pleased with what we were able to answer. And I'm just going to summarize what at least I've learned today. I'll start with the patients that we need to consider for imaging with F18 FDG PET for cardiac sarcoidosis kind of come in 2 buckets: those with an acute presentation, so new onset complete heart block, or malignant arrhythmias. And then the other bucket would be more of those with already defined cardiac sarcoidosis that come for serial testing in the setting of clinical concern for new inflammation. The other consideration in imaging cardiac inflammation with F18 FDG PET is on patient preparation. So there's different methods, not a lot of data, but in general, we want to do a combination of prolonged fasting and dietary modification with high-fat, low-carbohydrate diet. Another important point, I think, is we should consider doing perfusion imaging in all patients, advocate for whole body PET imaging in the majority of patients, especially for the first-time imaging to define areas of extracardiac sarcoidosis, which can sometimes help also to obtain tissue for a formal diagnosis. And then we should have a higher threshold for calling abnormal study when there is only lateral wall FDG uptake. And then we should also incorporate quantification of FDG uptake like Dr. Miller described. Thank you very much.
Thank you.
Thank you, Dr. Hutt, and thank you, Dr. Miller. This has been a great discussion. We've really covered a lot of ground from, who should you test? What's the best approach to testing? What's the best approach to interpretation? And then what do you do as the clinician downstream with the results? So thanks to you both. I've really enjoyed this, and I've learned a lot.